All right, so this is where we're going to talk about the physiological and psychological responses to stress. So this kind of goes along with when we talked about trauma and stuff like that. We're going to talk about the responses, cause and effects, mediators, management, and stress alleviation and health promotion. So stress can be positive or negative. Stress becomes negative when we're repetitively exposed to it and there's no opportunity to recover. This is chronic stress. The body is equipped to handle little bits of stress, but chronic stress is going to overwhelm the body. Okay? Over time, this is going to cause physical, emotional, and psychological disturbances. Different types of stress that we can have. We can have emotional stress. This is loss of self-esteem, internal conflict, grief, a loss of personal security, and perceived or actual fear, and cognitive issues. We can have physiological or physical stressors, which is an environment that's too hot or too cold, injury, illness, pain, substance use, and hunger. We can have environmental factors such as pollution, noise, and light. And then we can have psychosocial or relational causes. These are things like divorce, death of a partner or child, prolonged illness, a competitive work environment, trauma, move or change in job, and spiritual distress. So we have a couple of responses. The best known one is going to be the fight or flight. So we can either have fight, faint, flight, freeze, or fawn. So fight means we're going to face the stressor head on. Faint means we're going to limit the exposure to stress by physically fainting or going into syncope. Flight means we're going to run away from the situation. Freeze means we literally just freeze up and stop. And fawn means we attempt to please or give in to the stressor to make it go away. Okay. So we have stages of general adaptation syndrome. So this is our alarm stage, our resistant stage, and our exhaustion phase. So the alarm stage is the intense acute stress where the body provides the response to the stressor. We have the resistant phase where the body attempts to adapt, and then the exhaustion phase, which is when the body is just done, it has deleted all of its resources, and it has not overcome the stress, and it has no more to give. All of this can cause anxiety. So we have mild anxiety. This is when you're going to be introduced to a stressor. You're going to notice things like an increase in awareness. You're going to have the ability to problem solve and function. And we're going to generate a solution to the stress. So we may see things like things to try to relieve anxiety, like nail biting, foot tapping, or fidgeting. This is normal anxiety. This does not need to be treated. This is how your body knows something bad is happening. When we're unable to resolve the stress, we're going to experience moderate anxiety. And this is where the perception field becomes limited. They're not going to be able to concentrate. And we're still going to be able to problem solve, but we're going to not be able to learn new skills to problem solve. We're preparing itself for a physical solution to stress. This is where our vital signs are going to increase and our sympathetic nervous system is going to be activated. As the exposure continues, we're going to move into severe anxiety. This is when we have distorted perceptual field. We're not going to be able to focus on more than one thing at a time. We have, we don't really have a problem solving ability anymore. We pretty much feel like there is no solution. We have a severe level of anxiety that's going to be somatic complaints, which is where you get the headaches, the tummy aches, the back aches. We're going to have a sense of impending doom, withdrawal, loud speech, and even nausea. And then we're going to move into panic if it's still not resolved. During this time, we can't process the environment. We're going to have disassociations, and we may be disorganized and irrational. We may see things like hallucinations and delusionations as well. So we have an immune response to stress. This is where our body creates cortisol that weakens the immune system. And this is going to make us susceptible to infection. So this is where, again, stress is bad for our body. This is why you can get sick under times of stress. So there's eustress, which is kind of positive stress, and de-stress, which is bad. So examples of eustress or positive stress: birth of a child, marriage, buying a home, going into retirement, starting a new job, vacation, a promotion at work, graduation. All of these things are stressful times, but it's based off of a positive experience, where this stress is based off of a negative experience: death of a loved one, financial burdens, divorce, legal issues, high demands at work or school, abuse and neglect, relationship concepts, hospitalization of yourself and others, and injury or illness to yourself and others that you're close to. So again, difference between it's whether the trigger to the stress is positive or negative. So we have causes and effects of stress, and I know we kind of talked about this a little bit before. We have acute stress, which is response to a stressor and activates the stress response for a short period of time, and it's temporary. We have chronic stress, which is repeated and prolonged exposure to stress. This can be things like adverse experiences, trauma, and it's going to leave the person feeling overwhelmed. Chronic stress is going to, like we said, increase cortisol levels in the body, and we're going to have an impaired immune system. We're going to have cardiovascular issues. We can have autoimmune disorders, gastrointestinal disorders, obesity and diabetes. We're going to have reproductive dysfunctions, neurocognitive displays and disorders like we can have like delusions and dissociations. We're going to have depression, anxiety, insomnia, and we're going to have an increased risk of death. After we've experienced chronic stress for a long time, the body kind of learns that this is a normal state of affairs, and this is when we have toxic stress. Okay. So physical symptoms that may occur with stress is body aches, chest pain, exhaustion, insomnia, headaches, high blood pressure, muscle tension, weakened immune systems, palpitations. Whereas our psychological and behavioral is going to be things like anxiety, irritability, depression, panic attacks, increased sadness, excessive worry. We may turn to substance use or other addictive behaviors. We may have alterations in executive functioning. We may have delay development or regression, which is one of our defense mechanisms. We may develop an eating disorder or use compulsive behavior such as shopping and sex. So we have mediators of stress response. So we have individual factors which are within the person themselves. And these can be non-modifiable, such as genetics, while others can be changed within a person. An individual's perception and attitude influences how they will manage stress. This can include age, gender, life experiences, and socioeconomic status. The stressor alone is not going to determine how the person will respond to stress. We have positive things like self-perception, skills, and capacity, and are going to be a protective factor. We're going to have attitudes of hopefulness, resilience, and ability to handle challenging situations. But when somebody has a lack of control, a low self-esteem, low self-confidence, and a symptom of hopelessness, they're not going to be able to manage the stress as well. So temperament is going to refer to how an individual reacts to the world around them and is an aspect of personality. So we have the big 5 personality traits. So we have openness to experience, which is we're going to be curious, imaginative, artistic, kind of have wide interests and excitability, and have unconventional values. Whereas closeness to experiences, we're not going to be open to experiencing new things. We have conciseness, where we are efficient, organized, careful, thorough, diligent, and we're not impulsive. We can have the negative side of that is going to be a lack of direction, where we're none of those things. We can have extroversion. This is where we're social. We have our assertiveness. We're energetic, adventurous, enthusiastic. Or we can have introvertedness, where we're kind of the opposite. We have agreeableness, where we have trust and forgiveness. We're straightforward and not demanding. We're warm, flexible, humble, and sympathetic. We can have antagonism, which is going to be the opposite. And then we can have emotional stability, or we can have neuroticism, which is where we're tense, irritable, unhappy, moody, and not self-confident. So those are different ways that that's going to be in our mood and personalities. We have environmental factors that influence an individual's response to stress. This is going to be things like our socioeconomic, community, and family. We have physical locations and settings to foster wellness and increased place of increased risk, safe, secure, positive school and work environments. We can have negative environments that kind of have more pollution, crime, abuse, and this is going to foster negative issues, more stress. We have cultural factors, so typically close connection with one's culture is going to be support or a positive factor for stress management. We have lack of parental support is going to be a risk factor during childhood. When families communicate and provide safe, involved care for children and adolescents, we have a protective factor. When we have reduced interactions, increased loneliness, our ability to cope is going to be decreased. Of course, we have spirituality and religious practices are going to be a positive influence. and it's going to help us maintain our stress management. So stress is can have a negative impact on an individual. It is a common experience, so it's important to look at how people adapt and cope. Coping occurs when a person is learning to adjust to stress or a stressor while they stay within an equilibrium mentally and physically. The purpose, there's the Holmes-Ray statistical prediction model, which is going to see how susceptible you are to stress. So they're going to mark a value down for each experience they've had in the last year, and then you tally up the score. And I have attached in your packets a copy of this as well. But the higher the score, the greater the individual's risk for mental health issues. So 150 or less, we have a low susceptibility to stress-induced health problems. 150 to 300, we got about a 50% chance of a health breakdown within the next 2 years. 300 or more, we have an 80% chance of mental health breakdown in the next 2 years. So you'll kind of see what that looks like and what we're looking through. We want to assess coping styles within our clients. So we have problem-focused coping, which is adjusting or managing the problem that has caused the stress. It's action-focused. So this is going to be a client who creates a list or a plan on how to tackle the issue and resolve the stress. We have emotion-focused coping. This is going to be coping styles that reduce the negative emotions. So this is the client who seeks out support and resources to help their emotional health during times of stress. And then we have avoidant coping, which is cognitive and behavior efforts to diminish or ignore the stress. So this is going to be somebody focusing on they're going to drink or sleep all day in order to avoid dealing with the stress. So problem-focused and emotion-focused are going to be our positive coping mechanisms, whereas avoidant is going to be our negative coping mechanism. Okay. And then we have our defense mechanisms. I've stuffed a sheet in there that kind of shows you different examples of each. But we have altruism, which is transforming feelings and emotions by helping someone who's experiencing something similar. We have conversion. This is going to be unconscious process where psychological stress turns into physical symptoms. We have compensation, where we replace or create strengths in a specific skill set to offset the problem. We have denial, which is dismissing the situation, it's not even happening. We have disassociation, where there's a disruption in consciousness that disrupts the individual's perception of the environment. Memory or identity, that results in a separation of self. We have displacement. This is redirecting unacceptable feelings and thoughts to a less threatening target. We have identification, which is assuming the characteristics of another individual. Projection, which is going to be painful thoughts and emotions about themselves are put onto somebody else. Rationalization, which is going to be using reasoning and logic to avoid the explanation. We have reaction formation, where we replace unacceptable thoughts with feelings of the opposite emotion. Regression, this is where we return to a different developmental phase. Repression, this is where we put it down. Splitting, this is where there is no in the middle. If someone does something bad for you, if someone says no, they're 110% bad, there's no good about them. If they do something good, they're the best nurse in the world. We have suppression. This is where we choose to, again, we kind of push things down. And then undoing, this is where we try to do something to make up for the act that we did. So again, I put these with some examples within your packet, and we'll talk about some big ones in class to really understand. Okay. So big things is stress cannot be avoided. We have to understand the client's defense mechanisms and coping styles. We want to make sure that we adjust our expectations. We can use biofeedback and deep breathing. We want to help them develop positive self-talk and reduce blame. Use guided imagery and mindful meditation. So all of these things are going to help alleviate stress. So adjusting expectations is going to be avoiding disappointment and reducing stress by considering a very variable outcome so that you kind of know what's expected. You're not let down when something doesn't happen the way you wanted it to. We have biofeedback. So this is going to be monitoring physiological responses to a stress. And we're going to learn how to self-regulate. Deep breathing is taking those deliberate, slow, deep breaths. We want to make sure when we develop positive self-talk, we want to make sure that we're talking to ourselves with kindness and not doubt or blame. Using guided imagery is going to be breathing and moving into a calm, relaxed state. Typically, we're going to be visualizing a place that's calming, such as beach, park, waterfalls, things like that. And then mindful meditation is paying attention to what's happening in the moment instead of focusing on the stress. All right, so now that we've talked about how stress and trauma, how the body reacts to that, let's talk about some disorders with anxiety and obsessive compulsives. Okay. So anxiety is a normal response to stress and a common human experience. When the experiences of anxiety are temporary, they're going to motivate individuals in a positive way, such as when you're preparing to take an exam or performing in a concert. But when anxiety becomes excessive and begins to affect daily function, that's when we now have a disorder. Anxiety is going to be best understood by considering how anxiety affects a person's ability to function. Anxiety is a response that's based on a person's experience of stress. And like stress, anxiety is a survival response to help a person throughout a threatening situation. Okay, so we've already kind of talked about this. We have fear, that's an emotional response to a threat, whether it's actual or perceived. And these things can trigger anxiety and stress. We have the general adaptation system, which is very similar. I mean, it's the same thing as when we talked about stress. We have the alarm phase where we do fight, flight, freeze, or fawn. We have that cortisol release. That way we can kind of work through the stressor. We then have that resistance stage. This is where we're trying to return to a functional baseline. And then we have the exhaustion phase where our energy is depleted and we cannot self-regulate. Okay, so we've already talked about mild, moderate, severe, and panic. So mild is when we visibly become anxious, restless, requiring approval or reassurance. At this point, we're going to have heightened thinking. We're going to become more focused, and senses are going to become alert. This level of anxiety is going to help somebody study for an exam. So again, mild anxiety is not a problem. This is good and helps you. Without this, your body wouldn't know how to react in situations. We can move into moderate anxiety. This is where the symptoms continue, and we're going to be increasingly on edge, become frustrated, be restless, and be unable to sleep or concentrate. This level can be seen when you may toss and turn and can't sleep because you're worried about the loss of a job or loss of home, things like that. Moving into severe anxiety, the individual becomes overwhelmed with stressors and is normally used as a coping mechanism as no longer effective. We are going to have things like anxiousness, increased restlessness, decrease in cognition. Emotional response is heightened, including anger and irritability. This is going to become debilitating when the client cannot respond to others and cannot complete simple tasks, and has intense feeling of dread or doom. This can be seen in response to a parent with the sudden loss of a child, where they do not know what to do or who to call. And then we have panic, where the client becomes overwhelmed with terror and is at a point of exhaustion. They can no longer process stimuli within the environment, and they're unable to communicate verbally. They may become detached from reality, and this is where we're at a high risk for self-harm. So anxiety is become a disorder when the feelings of anxiety occur at inappropriate times or situations. The frequency and intensity increases and affects a person's ability to function, and the duration is increasingly prolonged. So that's when we have now gone to an anxiety disorder over normal, healthy anxiety. Obsessive compulsive disorder, which is OCD, and the other related disorders are precipitated by anxiety. OCD occurs when someone experiences obsession that are persistent and recurrent thoughts or urges that are unwanted, and then have compulsions, which are repetitive behaviors that are performed by the person to lessen or prevent the anxiety brought on. These become time-consuming and interfere with a client's ability to perform daily tasks. So, examples of obsessions: thoughts about being harmed or harming someone else, fears for safety, concerns for cleanliness or germs, fears that they are offending a higher power or deity, fear of forgetting something important, worry about how tidy or neatly arranged items are. Compulsions are going to be checking and rechecking that a door is locked, realistic order for hand washing, repeating specific words or phrases, hurting yourself, such as pulling your hair or scratching or biting, counting objects, items, or actions, and repeating an activity a specific number of times. So that's anxiety versus compulsion. We have both of those and have obsessive compulsive disorder. So anxiety and anxiety-related disorders are going to be triggered by a person's exposure to an environmental factor or stressor. Comorbidity is going to be manifestations of two disorders that occur at the same time within an individual. So a lot of ones that come with anxiety that kind of work, when you're diagnosed with anxiety, you're going to have a chance of being diagnosed with this: OCD, panic, trauma and stress, depressive disorders, substance use, somatic manifestations, sleep-wake disorders, eating disorders, PTSD, and medical issues such as pulmonary embolism, stroke, heart attack, cancer, sepsis, asthma, emphysema, pain, IBS, and delirium. Some risk factors that have been linked to anxiety are, of course, our trauma and negative life experiences, including our adverse childhood experiences, personality trait or temperament, including tendency for shyness and avoidance. So we kind of talked about that during the psychological, the trauma and the stress area. A family history of mental health disorder, history of illness such as cardiac conditions or thyroid disorders, genetic predisposition, and a lifestyle that does not include a healthy diet, exercise, and includes alcohol and substance use. Some comorbidities for OCD are going to be mood disorders such as bipolar and depressive disorder, obsessive compulsive personality disorder, which we talk about later on in the semester, tic disorders, and attention deficit hyperactivity disorders, oppositional defiant disorders, schizophrenia, spectrum disorders, substance use disorders, and eating disorders, which we all kind of talk about throughout the psychiatric part in our class. Lots of risk factors for OCD are going to be similar to those of anxiety, trauma, personality traits, family history, family medical history, genetic predisposition, and lifestyle. All right, so we have talked about ACEs almost all semester. That is going to be our adverse childhood experience. There is also PCEs, which is going to be a protective childhood experiences, which are going to be the things that help prevent mental health issues during childhood. So, of course, our ACEs, we've talked about this. Families experiencing caregiver challenges, youth who do not feel close to their family and cannot talk about their feelings, youth who start dating and engaging in sexual activity before they're developmentally ready, children and youth with few or no friends, families who have a limited understanding of a child's needs, families with caregivers who were abused and neglected as children, single parents, low incomes, low education, high levels of parenting stress or economic stress, caregivers who use spanking and other forms of corporal punishment for discipline, and low level of parental monitoring and supervision. Families that are isolated, families with high conflict and negative communication styles, family who is accepting and justifying of violence and aggression. So all of those are problematic family traits. Positive family traits are going to be families who create safe, stable, nurturing environments where they have consistent family life, where they're safe, taken care of, and supported. Children who have friendships, who do well in school, who have caring adults outside of the family who serve as role models. Families that can meet the basic needs of food, shelter, and health services. Families where there's a steady income. Families where there's a strong social support. Families where we work through conflict peacefully. Families that engage in fun, positive activities and encourage the importance of school. So all of these things are going to be how our clients develop and prevent mental health disorders. Okay. Oops. So when somebody, the biggest thing I want you to know before we move into treatment and signs and symptoms and kind of how everything looks, I want to talk about what your role is as we start getting into specific disorders, what your role is as a nurse. You're not here to diagnose, but you need to be able to critically think, recognize, report, and provide evidence-based nursing care for clients who have these manifestations. So things that you're going to be on the lookout for, be assessing for in anxiety disorders: apprehension, restlessness, irritability, anticipating the worst result, watching for what causes anxiety, avoidance of cause. We're going to look at their heart rate, their respiratory rate, sweating, exhaustion, GI disturbances, things like that. So what I don't want you to say, oh, this person has this because of this. What I want you to say is, oh, either A, the question's going to ask you, the person is displaying these symptoms. So in your head, you're going to say, okay, that's probably blank. And how can I best take care of them in the safest way possible? And then I want to say, this person has blank. What are my nursing interventions? How am I going to prioritize this problem? That's what I want you to be able to do. So we have anxiety disorders, and we talked about it. That becomes an anxiety or a disorder when it starts to interfere with everyday life. We have separation anxiety, which is experiencing developmental or inappropriate and excessive fear or anxiety upon separation from someone whom they're attached to. This is going to be reluctant to leave anybody. They're going to have nightmares and physical manifestations of distress. We have selective mutism, which is going to be failure to speak in social situations where there's an expectation to speak. Things like not talking in school when spoken to. Typically, we're going to have poor academic and social interactions, and we're not going to be able to communicate regularly. We have phobias, which is a specific anxiety upon exposure to an object or situation. This can be animals, nature, heights, vaccines, blood, anything like that. And then we have social anxieties, which is going to be exposure to social situations are going to cause the anxiety, such as meeting new people, being observed eating and drinking, or performing in front of others. Okay. We, of course, have panic disorders, which is going to be extreme periods of hyperarousal, and it's going to happen due to no apparent reason. Panic attacks are going to be an aspect of anxiety disorder, but we are going to have avoidance in the situation, people, or events that trigger an attack. We are always stressed and anxious about another attack, and they're typically time limited with a peak of intensity or fear of anxiety. Okay. Agoraphobia, which is anxiety upon exposure to circumstances associated with travel or location. So common situational causes: closed spaces, open spaces, leaving the home. A lot of times the focus is on not being able to escape, being embarrassed, or being incapacitated. Generalized anxiety disorder. This is going to be excessive worry upon different situations. And then, of course, we have substance use disorder that triggers anxiety. So this is when you use a substance and it makes you anxious. And then anxiety based on a medical condition. So this could be like hyperthyroidism. Okay. So then we have different types of obsessive compulsive disorders. So we have OCD, which is obsessive compulsive disorder. This is a pattern of obsessive thoughts and compulsions, behaviors, and rituals. Typically, it's manifestations of cleaning, hand washing, ordering and counting objects, and taboo or forbidden thoughts. We have body dysmorphic disorder, which is we're going to have a preoccupation with perceived flaws on your physical appearance. We're going to check the mirror a lot. We're going to do excessive grooming, skin picking, seeking reassurance. We're going to compare ourselves to others. And we could also have this could lead to possible eating disorders. So we'll talk about that later on in the semester. Hoarding disorders. Y'all have all probably seen TLC's Buried Alive. This is going to be a persistent difficulty or inability to discard or part with possessions that leaves overwhelming and cluttered areas. This can also become safety concerns. If y'all have ever seen Hoarding Buried Alive, these are true safety concerns. We have trichotillomania, which is going to be a ritualized behavior of pulling one's hair out. And then excursion disorder, which is going to be where we're picking at our skin. Okay. So some things that help us be diagnosed. Panic disorders is going to be recurrent and unexpected or unexplained panic attacks. They're going to be abrupt with a surge of intense fear. And these things are going to include palpitations, sweating, trembling, shortness of breath, feeling like you're being choked, chest pain, dizziness, chills or a heat sensation, numbness and tingling, feeling as if you're going crazy, fear of dying. Okay. And then typically these attacks have been followed by 1 month or more of persistent or concerned worry about additional panic attacks and significant maladaptive behavior related to the attacks. So that's going to be trying to avoid the triggers by going out of your way to avoid the triggers. Disturbance is not, and of course, these panic attacks are not caused by another thing like drug abuse, medication, hyperthyroidism, COPD, things like that. And we have generalized anxiety disorder, which is our GAD. Excessive worry or apprehension, more days than you don't for at least 6 months. We have it difficult to control worry. We have 3 or more of the symptoms of restlessness, fatigued, difficulty concentrating, irritability, muscle tension, sleep disturbances. And of course, once again, it cannot be the result of another disorder like drug use, medication, or medical conditions. For OCD, we have to have the presence of obsession, compulsions, or both. So obsessions being either the recurrent thoughts, urges, or images that are disturbing and unwanted, or the individual attempts to ignore with some thought or action by performing a compulsion. And then we're going to have compulsions, which is that repetitive behavior, and this is going to act as a way to reduce the anxiety. These are going to be typically time consuming and take up at least an hour of the person's day. And then, of course, is not else explained by a different problem. Okay. So some big things that you're going to want to know to take away from this is how do we care for somebody with panic disorder, GAD, and OCD? During the acute care time, panic disorder, we want to provide a calm milieu. We want to use therapeutic communication, grounding techniques, different behavioral therapies, things like that. Same thing with generalized anxiety disorder. A big thing that is always tested on for OCD is a priority nursing action aside from maintaining their safety, especially if the intrusive thoughts are things like homicide or suicide, is allowing time for their rituals throughout their care. That is always a big piece in caring for someone with OCD. Okay. So we want to make sure that we're working in using trauma-informed care, universal trauma precautions, and not re-traumatizing the person. We want to make sure that we're thinking about the following concepts, like safety. Does what the health team and I do give a sense of safety? Am I showing my client respect? And does what I say and do build trust with my patient? Okay. We have unconditional positive regard, which means we have to project a sense of acceptance and good to minimize shame and stigma. So it's okay that you have this disorder. I'm still here for you and you're safe. It doesn't matter. We've already talked about transference and countertransference. We just have to make sure we know what those are. A big thing is anxiety cannot always be prevented, but when it becomes difficult to handle, once again, we're having issues. We want to make sure that, like we said, we're supporting our clients. We're using active listening. We're using therapeutic communication. We're using modeling. This is where we demonstrate the behavior that a nurse would want to see. So this is like when a client's manifestation of panic stops. We can sit down next to the client and begin breathing slowly and deeply, and hoping that they'll mimic our behavior of the deep breathing. Of course, milieu management, we've talked about. Anticipatory guidance, we've talked about. Anti-stigma messaging. This is, we want to make sure that we are not promoting the use of stigma-inducing vocabulary. So this can be things like when a family member says the client's anxiety is all in their head, we need to remind them that it's a real disorder and it's very real and they're not quote unquote crazy. We want to make sure we understand what their triggers are so that we can help them approach their triggers and cope with them. Of course, we want to use support and things. We're going to use things like psychotherapy, which is that talk therapy, cognitive behavioral therapy, which is thought redirecting, cognitive therapy, exposure therapy. So this exposure therapy is going to be used a lot in phobias, where we gradually get you to a point where you are doing what you need to do. And then, of course, we have integrative approaches. This could be things like making sure that we're using the right relaxation techniques, hypnosis, massage therapy, mindfulness, music, and make sure that we are helping them do positive lifestyle management, like make good choices on nutritional, healthy diets, exercise, and avoiding caffeine and substances that can really trigger anxiety. We have anxiety-related disorders are going to be typically treated with things like analytics, such as our benzodiazepines and our non-benzodiazepines like the buspirone, our SSRIs, and our SNRIs. So those are some meds that you're gonna have to remember from pharmacology, and I'm gonna make sure I drill them back into your head. And then, of course, the education that we're going to provide is going to be things like medication management, talking about different coping mechanisms, making sure that they know how to keep a healthy diet, exercise regularly, and know when to understand that things are getting worse and they should see a provider, and what a mental health emergency is, like suicidal thoughts or ideations or actions. So those are some big education points for our client. So when we're going through our nursing process, of course, we're going to assess the client with anxiety. We want to make sure that we're recognizing clues like the manifestations, things that make the anxiety worse or make it better. We want to make sure that we rule out any kind of physiological cause like thyroid, glucose, heart, toxicology screenings, things like that. What kind of things are in the manifestation are most distressing right now, and looking at the client's history, looking at the family history, looking at the client's readiness to change, and to what extent of the client's function has been affected. There are a lot of different evidence-based screening tools. This can be used, things like the mental status exam, a safety screening, or any kind of tools that are used within your facility. So there's not a specific one for this, but there's just a couple, and all it's going to do is it's really just looking to see how much it affects your life. Okay. Once we've collected all these cues, we're going to analyze them. And with that, we're going to do things such as prioritizing care with the client using safety. Remember, these clients are at high risk for death by suicide. So we want to make sure client safety is assured. And then we're going to target the manifestations. We want to look at the client's ability to effectively cope, their thought processes, their physical and psychological symptoms, and identify a plan of action. So when we take action as a nurse, where we implement our things, we're going to use interventions such as verbal communication. How can I communicate with my client to help reduce their anxiety? How can milieu changes? How can I change the environment? Seclusion. Is my client in acute danger to themselves or others? Because then we may have to do a seclusion. We may have to move to a mechanical restraint or a chemical restraint if they are actively trying to hurt themselves, and seclusion is not enough. Of course, just as always, we are going to go least restrictive to most restrictive. And then, of course, we're going to evaluate and see if the plan worked and what needs to be changed and what we need to continue to do to help this client. All right, so this is going to talk about somatic symptoms and dissociative disorders. So I know throughout the anxiety and the trauma lecture, I talked about the word somatic and dissociative. So this is kind of going to go into a little more deeper dive of what those words mean. So somatic symptoms are going to involve physical manifestations that are not explained by physical or mental health disorders. Clients who are diagnosed with a disorder are not faking their manifestations. That's an important distinction there. And manifestations such as pain, GI issues, and sexual difficulties are real. The severity of the symptoms can sometimes be exacerbated because they feel hopeless and helpless because they cannot be scientifically explained. Illness anxiety disorder used to be called hypochondriac. This is a client who experienced constant thoughts about having an illness, and the client is often misinterpreting their symptoms and may seek extensive treatment to try to relieve their anxiety. So functional neurologic symptom disorder, which used to be known as conversion disorder. This is where clients are going to experience motor weakness, paralysis, tremors, reduced tactile, visual, and auditory sensations, and syncope, meaning they fall out. All tests are going to be negative. When I worked in neurology, this was called a pseudo seizure, pseudo meaning not seizure. So it would look like they were having an epileptic seizure, but on the ECG, they would not be having a seizure. So this is used to be known as conversion. So this is when we have neurological symptoms displaying with no underlying reason. Factitious disorder is when someone falsifies their symptoms to themselves or others, even when there is no reward for doing so. So we may self-induce or fabricate symptoms. We may an example of this is putting blood in their urine or stating suicidal thoughts that are not actually there. If the client does these things for a personal gain, such as getting out of work, this is called malingering. So the difference between factitious disorder and malingering is the personal gain awarded from it. Factitious disorder, no personal gain. Malingering, personal gain. We have our dissociative disorders, and these are characterized by a disruption in the way that memory, consciousness, identity, emotions, motor control, and behavior interact. We can have dissociation that's present in a person who has experienced a lot of trauma. So that's why we talked about this a little bit when I talked about the trauma lecture. When a client experiences dissociation, they may be re-experiencing a previous trauma, switch to an alternate personality, such as DID, or have flashbacks and nightmares. This is a defense mechanism that the client does unconsciously to protect them from anxiety and stress. So we have depersonalization or derealization. This is when a client is detached from their surroundings. They may describe it as being an out-of-body or dreamlike experience, but the client can still test to reality. They know what's going on around them, and it's what is going on around them they can accurately describe. Dissociative amnesia is going to be a client who is unable to recall events related to their history, and this is not consistent with normal forgetfulness. This may be when a client cannot remember specific things about an event or their personal history, and this will not affect their ability to remember events in the future that are not related to trauma. The events that they are forgetting is typically traumatic events that have happened. And we have dissociative identity disorder, DID. This is going to be this used to be multiple personality disorder. It's sudden and temporary changes in consciousness, behavior, and identity. We're going to get a diagnosis when a client experiences a disruption of identity characterized by 2 or more distinct personality states. There may be recurrent gaps in memory of everyday life. Typically, we're going to have at least 2, if not more, separate identities, also called alters. And they function independently from one another. Those are our 3 main dissociative disorders. And these are all a way of dealing with stress through a defense mechanism. Okay. So it's not really sure where somatic symptom disorders stem from, but we think studies are showing risk factors like ACEs, adverse childhood experiences, child abuse, neglect, and sexual abuse, and a history of substance use. A lot of clients with somatic manifestations are underdiagnosed because the disorder is very stigmatized. Dissociative disorder, most individuals who have it are going to report some form of early childhood abuse and trauma. Whether there are clear signs of abuse or not, it's possible that the client may have been exposed to a dysfunctional family dynamic. And things like separation anxiety or over-controlling parenting. These can manifest into dissociative symptoms as well. It can be exacerbated by continued trauma like intimate partner violence, abuse, and medical illness. Some comorbidities that we're going to have with somatic disorders are going to be things like major depressive disorder, panic disorder, agoraphobia. They're going to have some suicidal ideation and potentially some history of suicide attempts. So that's a safety trigger for us as nurses. A lot of times we may also have a personality disorder, which we talk about later in the term. Dissociative identity disorder. Comorbidities are typically PTSD, substance use, antisocial personality disorder, and depressive disorder. After dissociative amnesia, a lot of individuals experience guilt, rage, and dysphoria. So those are all some things that can happen with the dissociative and somatic disorders, are risk factors. So of course, in order to have a somatic or dissociative disorder, all in all, you're typically going to have some form of triggering event that causes high stress, high anxiety, that our body then uses these somatic and dissociative symptoms to try to make us feel better about it. So, somatic symptom disorder, we're going to have typically 1 or more somatic symptoms that are distressing and result in disruption of daily life. We're going to have excessive thoughts and feelings about the somatic symptoms. We're going to have a persistent high level of anxiety about health. We're going to have excessive time and energy devoted to these symptoms. And they're typically going to last around 6 months or more. Those who have somatic symptom disorder may present with multiple medical complaints at once with no identifiable cause, even though there's been extensive workup. Clients will typically seek out medical help in an attempt to identify the cause, but are typically unwilling to seek psychiatric help. So that's going to be a really hard piece to work through, is getting them the psychiatric help that they truly need. Anxiety related illness anxiety disorder. We're going to have constant researching specific manifestations. We're going to exaggerate our manifestations. So this is your friend who always thinks because they have a really bad headache, they have a brain tumor. They're going to be obsessive about body functions and vital signs. So this is, my blood pressure was a smidge high today, and I'm going to freak out about it and go on a crash diet. High levels of anxiety around stress, and then lots of oversharing about manifestations to try and have someone agree with them. Oh yeah, this is probably a brain tumor. For functional neurological system disorder, we're going to have neurological manifestations without a medical cause. So once again, this is going to be typically manifestations are psychiatric. These are going to be things like emotional distress that are displayed through physical symptoms that become more apparent during times of acute stress. This could be blindness, paralysis, an inability to swallow, or impairments in walking. Okay. And then in factitious disorder, we're going to have a client who is knowingly producing manifestation to assume the sick role. We can have factitious disorder that is imposed on an individual, or factitious disorder that is imposed on another. So back in the day, this was called Munchausen's. So Munchausen is when you do things to yourself in order to get the results you're looking for. Munchausen's by proxy, or this type of another imposed onto another, is when you do it to somebody else. So this is going to be like, I don't know if anyone's seen it, story of Gypsy Rose. She was a victim of Munchausen by proxy. Clients a lot of times are going to misrepresent their manifestations and maybe deliberately injuring or infecting themselves to get their emotional needs met. This behavior, it's going to lead to a lot of diagnostic procedures and hospitalizations that are and treatments with adverse effects that are not needed. So that is going to be our factitious disorder. And then, of course, when this is done for personal gain, not emotional gain, when it's actually done to get something in return, money, time off work, etc., that's when it becomes malingering. So we talked about dissociative amnesia. So this is going to be that inability to recall or remember experiences that are stressful. This could be related to a specific memory, or may include a lot of a client's history that they blocked out over a long period of time. Typically, the memory loss is short, and when the memory returns, the onset of the memory returns and is sudden and complete. So a lot of times we work through psychotherapy to get these memories back and face the trauma instead of dissociating it. Depersonalization disorder, we're going to, again, feel that disconnect from their body. A big description is feeling like a robot. They may feel like they're a giant and the stairs are really small, kind of like Alice in Wonderland syndrome. It actually, there is a disorder that was called that, and it's very similar. And of course, these happen usually during, after experiencing a traumatic event or periods of high stress. And then we have our dissociative identity disorder. Remember, this is going to be two distinct states of personalities. They're going to work in separate of each other. We're going to have recurrent gaps in the ability to recall things from everyday life. There's going to be some traumatic events that are not remembered, so you may have some of that dissociative amnesia with the DID. In children, this is really hard to diagnose because it can seem very similar to imaginary friends. And of course, we have to make sure that it's not anything like these memory losses and lapse in time are not done from substance use or seizures or anything like that. So for any of our somatic and dissociative disorders, one of our big treatments is cognitive behavioral therapy. Relaxation therapy is another big one. Grounding techniques, such as taking a shower, holding onto an object, doing 5, 4, 3, 2, 1, identifying 5 things you can see, 4 things you can feel, 3 things you can hear, 2 things you can smell, and 1 thing you can taste, to kind of get your mind in a different area. So that's our clinical presentation and some of our treatment for dissociative. So of course, when somebody experiences these symptoms, they need to receive a medical and physical evaluation to make sure that these are not potential life-threatening emergencies, especially if somebody with factitious syndrome says chest pain. Case management is going to play a big role in this to help control their costs and make sure they're not doctor shopping. So the goal of treatment is, of course, going to be reduce anxiety and increase the quality of life. So this may be done with things like SSRIs or SNRIs. And then, of course, psychotherapy and cognitive behavioral therapy will work as well. When working with functional neurological symptom disorder, psychotherapy and CBT are standard treatment. We also may have to do physical therapy to get their gait back. And antidepressants and anti-anxieties often also can help if a co-occurring cause is anxiety and depression. Our job as nurses are going to be to work with them and develop good coping skills to reduce their stress and anxiety. For factitious disorder, our goals of treatment are going to be to keep the client safe and reduce the number of unnecessary treatments and tests, while also making sure we're not falling for the boy who cried wolf and having that one time that it's actually something real. Psychotherapy is treatment of choice. And then, of course, our SSRIs to treat the anxiety and depression that comes along with it. Some challenges for clients who have factitious disorders is that clients will often go from provider to provider or hospital to hospital. And they're going to have a reluctance in allowing healthcare professionals to talk to their family member, friends, or other healthcare providers. Clients with this disorder, like we talked about, have a significant harm to themselves or others, especially if it's imposed on others. And then they may be emotionally labile or angry if we do not follow through with their request for treatment or testing. So those are some things to kind of be on the lookout for with factitious disorder. For somatic symptom disorders, effective therapeutic communication is essential. They're going through so much and they're so stressed. In order for them to trust us with their care, we can't just sit there and say, sit down, you're faking it. That's not going to help them. We want to make sure we're encouraging healthy physical and social activity, sleep, and hobbies. And we also want to discuss benefits of certain therapies and coping skills that they're learning, like our relaxation techniques, our CBT and mindfulness, our cognitive reframing. We want to make sure they're setting realistic goals. And we are providing somatic symptom relief, such as pain medication and digestion relief. But we're also going to have to do a good assessment on what has helped the client in the past. Because remember, their symptoms are real. There's just not a reason as to why it's happening. We already talked about it, making sure that we're not using judgmental statements like your symptoms are in your head, you're making it up, there's nothing wrong with you. And then we want to focus on medication education and adherence, and make sure we're having good communication with our patients. For dissociative disorders, a lot of times the priority goal for clients is safety of the client, because a lot of times, remember, they exhibit that suicidal ideation and self-injurious behaviors. We want to provide therapeutic environment, milieu, and communication. Therapies such as psychotherapy, DBT therapy, and EMDR therapy are very effective in DID. The goal for dissociative amnesia is for the memories to return and that the client is able to safely process them. We're going to help them maintain as much function as possible and use our coping skills. We want to make sure that we're assessing for safety and suicidal thoughts with dissociative amnesia, that we are encouraging them to participate in psychotherapy, cognitive behavioral therapy, and dialectical behavioral therapy. There are no specific medications, but we do want to help them with the comorbidities like the depression and the anxiety. So we want to educate them on those medications. For depersonalization, again, psychotherapy, antidepressants, and just therapeutic communication. When we are assessing our clients, this is going to be a very difficult process. We have to carefully assess the onset, location, duration of the manifestations. We also have to assess the client's use of medication. And we also have to assess the coping skills and communication abilities of the client. We need to make sure that we do a complete and thorough assessment, because if new symptoms are present, we have to make sure that we're documenting these things. And we already talked about we must manage, prioritize safety and manage the anxiety. Somatic symptom disorders, we have to work with our clients because they may have issues communicating their needs. We need to make sure, again, safety is our priority, risk for suicide. So the biggest thing that we're going to do with nursing is going to be building that therapeutic relationship, making sure that we're helping identify coping skills that are positive and utilizing them with the clients. When somebody is having issues with like the amnesia and the memory, we may want to do simple routines. We want to make sure we're checking for orientation. And make sure, once again, we have a safe and controlled environment, and we're monitoring for suicidal thoughts and ideations. That's your biggest goal as a nurse, is keeping these guys safe.